is the top of the hour. Welcome, everyone. I know there's going to be a couple more people straggling in, but not to worry. We're going to do a couple of just super high level framing before we get started into the meat of the presentation. So, welcome, everyone. We're so glad that you decided to join us for this hour-long webinar. I am Stacia Johnston, Director of Health Equity Advancement at ACLM. I am on ACLM's Practice Advancement team, where we uncover the how of lifestyle medicine. So, simply put, that means we lean into our members and LM clinicians nationwide to explore what they're doing in the field and the impact their programs are having as a way to leverage learnings and scale successful programs within various health settings, including FQHCs. As our speakers today, you'll learn more from in a moment, go through the presentation. Please feel free, as I mentioned earlier, to submit your questions in the Q&A platform, and also make a quick introduction in the chat so we can get to know who's in the room. We'll respond to some of your questions in real time in the chat, or we'll save some for at the end when we have our Q&A session. So please do feel free to add some comments and questions over in the chat. Thank you, Gabby, for going to the next slide. Okay, so Gabby, can you go up a little bit? I wanted to introduce everyone to lifestyle medicine quickly. I'm sure there's a lot of people in the room who are familiar with lifestyle medicine, but for those who may be new to this specialty, I just wanted to lay some groundwork on framing. So we have a jam-packed session today, but I do look forward to exploring one of the innovative ways that LM clinicians are making lifestyle medicine accessible, particularly by leveraging strategic partnerships. So before we dive in, let's talk a little bit more about lifestyle medicine. So, lifestyle medicine is a medical specialty that uses therapeutic lifestyle interventions, like the six listed on the slide, as the primary modality to treat chronic conditions, including but not limited to cardiovascular diseases, type 2 diabetes, and obesity. Next slide, please. So, I work closely with leaders of ACLM's Health Equity Achieved Through Lifestyle Medicine, or HEAL initiative, to support LM clinicians in their efforts to make LM accessible for all special populations. Today, we'll be discussing an FQHC's approach to delivering lifestyle medicine to a rural community. ACLM works with strategic partners to advance its health equity efforts. One of those partners is ACU, or the Association of Clinicians for the Underserved. For about 2 years now, we've collaborated to bring educational content to lifestyle medicine to their members, while leaning on ACU as a resource to better understand the unique needs of health center providers, especially those that are trying to improve chronic diseases among their patients. Next slide, please. So speaking of ACU, I want to introduce you to today's moderator. Suzanne Spear is Vice President of Workforce Development at ACU. Suzanne, thank you for being with us today. I think this is our third joint webinar together, and we always have a really good time. So I'll kick it over to you to share a little bit more about ACU and lead us in today's session.
Wonderful. Thank you so much, Stacia. And thank you, all of you, for being here today. Really excited for this webinar, which is our third webinar of our partnership with the American College of Lifestyle Medicine. And just really excited to be here today. A little bit about me. I've been working with community health centers since 2012. First, I recruited providers directly from with the Virginia Community Healthcare Association, and I've been with ACU for almost 8 years now. And I currently serve as the Vice President of Workforce Development, overseeing all of our workforce programming. Next slide, please. And for those of you who aren't familiar with ACU, or if you are, then this will just be a reintroduction. ACU is the Association of Clinicians for the Underserved. We were founded about 29 years ago by alumni of the National Health Service Corps. And while we have changed a lot over the years, our mission remains the same, and that is access to care for underserved populations and supporting those who are serving underserved populations. And our one part of our mission is really that health equity piece, right? Making sure that underserved communities get the care in which they deserve. And that part of our mission aligns perfectly with the ACLM mission of that lifestyle medicine piece. And as the speakers that were talking a little bit earlier today, just there's so much more to health than most folks know. And so I'm just really, really excited for this continuing partnership with ACLM. Next slide, please. Just wanted to let y'all know of an exciting opportunity coming up here soon. ACU has their annual conference every summer in Washington, D.C. And this year, our theme is the power of advocacy and the promise of primary care. Again, it's going to be held in Washington, D.C. the first week of August. And I'd invite you to take a look at our agenda and look at all of the exciting speakers we have. We have some amazing and wonderful sessions, all of the educational sessions, and then we really have some amazing keynotes. So I would encourage you to go to our website and take a look. And if you're interested and you're able, come and register for our conference. We're really, really excited about that coming up here very soon. And so just wanted to, as your moderator, I wanted to introduce you to our two amazing and extremely enthusiastic and very qualified speakers today, talking about shared medical visits and lifestyle medicine. So first we have William Kupel, who is a certified physician assistant with Albany area primary health care. He earned his Bachelor of Science degree from Georgia Southwestern State University in Americus, Georgia, and completed his Master of Science in Physician Assistant Studies at A.T. Still University in Mesa, Arizona. He has worked in psychiatry and internal medicine since 2019. He was certified through the Institute for Functional Medicine in 2023 and obtained his certification from the American College of Lifestyle Medicine in 2024. Will quickly realized that lifestyle factors play a major role in the health of his underserved patients. So he created a shared medical appointment in 2020 entitled Fresh RX. This program covers lifestyle medicine implementation as FQHC. Additionally, each participant of the shared medical appointments is given a box of fresh produce to implement into their diet. The Fresh RX program received national attention at the NAC conference in Atlanta, Georgia in 2024. His passion is to continue collaborating with like-minded individuals and professionals to implement shared medical appointments and lifestyle medicine into FQHCs across the nation and decrease the burden of chronic disease in America. Second, we have Annette Bettridge, and she is a physician assistant and faculty member at A.T. Still University in Arizona, where she plays a key role in advancing clinical education and wellness initiatives. She has supported the development and implementation of the Fresh RX shared medical appointment wellness visit. AT Still, a national academic institution with clinical training sites at FQHCs across the country, is a collaborative partner in a grant proposal currently under the review with Ardmore Institute of Health. The proposal aims to develop a scalable SMA, or shared medical appointment, model using Ardmore's full plate living curriculum designed to promote plant-forward nutrition and chronic disease prevention. And with that, I'll turn it over to our speakers for today.
Thank you for that introduction. I just want to say I truly appreciate ACLM giving us this platform. Nat and I have been working on this project for 4 or 5 years. We've poured our hearts and soul into it, so it's just great to be able to share this. As Suzanne shared, I've worked in psychiatry, internal med, functional medicine, and it doesn't really matter what patient we're dealing with. If we can get these pillars of lifestyle medicine right, that's going to benefit all the patients. So that is one of my passions to bring this to a national stage. And I'll let Annette say a few words.
Yes, well, it was said so well by Will. I echo his passion for serving the underserved and addressing the social determinants of health and putting lifestyle interventions first and foremost in the treatment of patients to prevent or reduce the complications of chronic disease. So thank you for having us here today. We're excited to be here. And it's been really fun to see everybody from all over, actually the nation I see, joining us today. So we hope that we can share with you some good tips. So our goal today is to paint a picture of what we're already doing with shared medical appointments and how we've combined the efforts through an academic partnership. I am training PA students and overseeing PA students who go out to Will's FQHC and then implement the shared medical appointment. So we want to share what that looks like, share tips and tools and strategies with you, and we welcome any questions that you have. We hope to have a great discussion afterwards. Next slide. And next slide.
Yep. So like the last slide showed, the name of our program is Fresh RX. So I just want to kind of tell a story of how Fresh RX came to be. So growing up myself, I was raised by really great parents. However, they did not really understand nutrition. So we were fed a lot of processed foods, and ultimately I showed up to my pediatrician. I was morbidly obese at 10 years old, and they basically said, here, take some metformin. We didn't really have any discussions about lifestyle or diet or anything. So I kind of set about the next few years of my life and on into college to figure out, how to get into shape, what to eat, how to exercise, basically learning these pillars of lifestyle medicine. And then going into college, I started studying exercise science. I thought I may have wanted to be a trainer, or I don't really know what I wanted to do at that time. And also in college, I ended up getting injured, and I was prescribed opiates, and eventually something clicked and I became addicted to these opiates. And eventually I just could not figure out how to stop these things. Eventually I got sober, and through lots of prayer and searching out to God, he basically told me, I want you to get into helping others who struggle with their weight and addiction, because I truly think those two go hand in hand. Addicted to certain foods, drugs, it works very similar in the brain. So once I had my sobriety, I applied to PA school. I'd actually never heard of a PA. Luckily, I was working at this psychiatric unit at the local hospital. I ran into a physician assistant, and he told me about the Hometown Scholars Program, where basically if you were from this area in rural Southwest Georgia, they would send you out to Arizona at AT Steel, and then you'd come back here and work in the community you were from. So I said, that sounds like a great idea. So in 2017, I went out to Arizona to start physician assistant school, and that's where I met Annette. And as you see the picture there, Crossroads, that is a substance abuse facility that Annette was taking students to. So it was like just one door opening after another that God opened for me to help people with addiction and obesity. So me and Annette met there. I graduated in 2019, came back home, started practicing. I started doing 3 days of psychiatry, 2 days of internal med. I was ready to save the world. But I quickly realized that most of what I'm doing is just putting people on medications. We weren't really discussing lifestyle medicine. We didn't really have time. As a lot of you clinicians know, in actual practice, it's very fast paced. We're 10, 15-minute visits. You're basically reserved to prescribing medications. although you can, sneak some lifestyle medicine in there. But I quickly realized with these underserved patients here in Albany, Georgia, that most of what they were struggling with was chronic diseases due to poor lifestyle. So me and Annette game planned. My wife, shout out to her, she really helped me get this together also. And then we launched Fresh RX in 2021, I believe, with the help of the PA students. And then we've been slowly tweaking it every year, just trying to make it better. Anything else you want to add there, Annette?
Yes, I want to also share that I'm passionate about this because I too have been morbidly obese, and I come from a family that has really struggled with morbid obesity and type 2 diabetes. In fact, I'm the only person in my family that does not have type 2 diabetes. And I could see my family going on this trajectory of complications due to their health conditions. It was a real wake-up call for me. And I realized if I didn't want to continue and follow that path, I needed to do something myself. So I personally put lifestyle treatments first and lost 70 pounds. I've been able to keep it off for 2 years, every day, one day at a time. And so I'm very passionate about this, and I'm really passionate about helping people avoid risky substances, because I feel like, as Will said, food can be an addiction too, and it definitely is for me. So the more we can set patients up for success and give them tools and treat food as medicine is beneficial. I had to change my mindset from living to eat to eating to live. And it's made a difference for me. And we try to convey that to our patients. Next slide.
So these are the 6 pillars of lifestyle medicine. And these are basically the ingredients that every human being needs to function, right? Like I was saying, in actual clinical practice, we don't really have time to discuss these things. So that's why I think a shared medical appointment is vital to a federally qualified health center. Another thing ACLM offers is they offer a scholarship to one provider at any FQHC across the nation. My CEO sent me that information, and I jumped on it. And basically, through going through the certification, I realized basically, Annette, we were doing lifestyle medicine, but this just gave us a better framework. So like I said, the groups, basically we're discussing these topics here. And at the shared medical appointment, really the goal is not for me or the students to just stand up there and talk at the patients. It's more like, you see the picture there, sitting around a dinner table, a friendly conversation. Really where I came up with this idea was from getting sober. I went to AA, Alcoholics Anonymous, and Narcotics Anonymous. Basically worked the 12 steps. And in those meetings, those are some very powerful meetings where you basically sit around in a circle. Any of those that have ever been to AA or NA. But basically it's a group of people who are struggling with something. And we sit around in a circle and we discuss options to get each other better. There are people that are further ahead in their sobriety. And so that's basically where the idea came for these shared medical appointments. I had no clue that people were doing these all across the nation. But once I got in with ACLM, I truly feel like I found my tribe of people, because I truly feel like they realize that the current medical paradigm is not sustainable. So we have got to interject this into modern medicine, especially in these federally qualified health centers, where a lot of these patients are very, very sick. Next slide. So like I was saying, the federally qualified health center that I work in is in rural Albany, Georgia. Basically what this slide shows is the population here in Albany, Georgia is twice as sick as the national average. So we have almost 22% here are type 2 diabetics. The national average is 11.6%. Have a lot of poverty here. And then the other statistic that I think is definitely worth pointing out is 75% of the population identifies as Black or African American. And African Americans are 2.5 times the risk of diabetic complications, 3 times the risk of being hospitalized from diabetic complications, and 2 times the risk of diabetes-related mortality and comorbidities compared to their white counterparts. And I can 100% attest to this. I see this every day in the clinic. It is nothing for me to see an A1C high of 14, strokes, heart attacks, just very chronically ill patients. And I honestly think it is a social injustice the way that we are running the current medical paradigm. Like I said, we've got to do something to help these underserved patients. And I'm just excited that ACLM is giving us this platform to talk about this, because I definitely think with these shared medical appointments and discussing lifestyle medicine as a baseline, we can eradicate a lot of these chronic diseases that I see day in and day out, not only on the medical side, but also on the psychiatric side. Anything you want to add there, Annette?
I see that this is also happening in other FQHCs that I visited around the whole nation. So I agree with you that this is a really big problem that we need to address. And I feel that it's important to train our trainers better how to address this, so they're ready to start educating and supporting on day one when they enter clinical practice. Next slide.
All right, so this is just more statistics on Albany. The main thing that I wanted to point out here is the term food swamp. I don't know who coined that. Annette told me that term, and it was kind of like a light bulb going off. And I truly think that is one of the main issues here in my area is patients have lots of access to highly palatable, highly addictive, highly processed foods, and they basically get addicted to it, for lack of better words, and it leads to all these chronic diseases. Even though we're around, there's lots of farms around this area, but access to fresh produce, fruits and veggies, is very difficult and hard to do. So that's one of the things we do at the shared medical appointment. We bring fresh produce to the group and teach the patients how to implement it. Another stat that I thought was interesting was that 5 to 7% of SNAP benefits are spent on sugary beverages. So that is something that we definitely need to take a look at. And I'm not at all trying to get political here. I'm just trying to share my experience of working at a federally qualified health center. And it's evident that what my patients, white patients and Black patients alike, are eating is contributing to their health. So that's the first thing that we have to start addressing are these 6 pillars. Next slide. So this is just more, so the last couple slides were Albany, Georgia. This is more just as Georgia as a whole. Yeah. So diabetes has surged 20% in the state. Nearly 1 million people are diagnosed and 3 million are developing the disease. And I don't think this is just a problem in Georgia. I think nationally, 70% of Americans are overweight and the health of the nation is steadily declining. I think we spend more on healthcare than any nation, yet our outcomes are not that great. I think that we do a really good job with acute care, chronic care. I think we definitely need to focus more on these lifestyle changes, which I think ACLM is going to lead the charge for this. Anything you wanted to add there, Annette?
No.
All right, next slide. All right, so addressing the social determinants in Albany, Georgia. So it's a collaborative effort, right? So I basically had this idea 4 or 5 years ago to create this group. And that I tend to have lots of bright ideas. but to actually make them happen, Annette has been huge, helping me get organized, helping just put it down on paper. My wife, if she's on here, she has been a huge help also. And then also bringing in, collaborating with local farmers. Like I said, the local farmer Fredo is what we call him. He's heavily involved in the community, and he brings about 10 or 15 boxes of fresh produce to each group. And then at the group, we open up the produce boxes and we discuss, how are we going to implement this into our lives? And it comes up with some pretty good discussions, because like I said, we're not really teaching at the group. We're just presenting a topic, and then the group kind of takes shape with the participants. They're basically carrying the group, and if they have any questions, we're there to answer it. We also, Albany Area Primary Healthcare, which is the FQHC that I work at. They have been great helping us implement this. And then, of course, Annette, she is a faculty member at AT Still in Arizona. She helps me tweak this every year. And then every year we get 5 PA students from Arizona that come to Georgia, and they help me deliver these shared medical appointments. And then they've also been tracking data on these shared medical appointments for the past 3 or 4 years, which is essential for applying for grants, which I did not realize that. Annette did, obviously. So that's another way that she and AT Still has been super helpful. Next slide. All right, so this is a picture of the group here. So basically, once a month, we meet for 2 hours. We present a topic. We've been using basically the 6 pillars of lifestyle medicine. We kick it off, and then the participants talk. We kind of go back and forth about the topic of the day, and then we end with the fresh produce. We've got a few more stats here on just the cost of chronic disease here in America. And one of the things I highlighted here on the bottom is we aim for early education. Like I said earlier, my wife has been a huge help in this. She was also a graduate of the PA program. And so she also works for the Federally Qualified Health Center here in Albany. She is a physician assistant at one of the local public schools. And she has opened, her and another nurse practitioner have opened 2 of these wellness groups in the local public schools. And that is one of the main things that we're trying to do with these groups, is to educate the younger generation. It's although we want to help the adults, obviously, I'm going to keep the adult groups going. We all know it's hard to talk an adult into making these lifestyle changes. But if we can reach the next generation by getting these groups into public schools and reaching that younger generation, then hopefully we can start to turn the dial on these chronic health conditions. Next slide.
So AT Still, we were so pleased to make this partnership with Will, because our mission is really to serve the whole person, body, mind, and spirit, and provide culturally humble care to underserved communities. And so I've had the unique experience and privilege of being able to teach a course called Body, Mind, Spirit, and also a behavioral health course. And through those courses, I've integrated a lot of behavioral change content, patient adherence, motivational interviewing, which is really key to having those conversations with patients to help them build their own intrinsic motivation to make a change. We also touch on health literacy and social determinants of health, patient education, mental well-being. And so in my courses, we're touching on those pillars of social connectedness, stress management, avoiding risky substances, and sleep. In the other courses within AT Still, they're covering nutrition and physical activity. And then all of the faculty oversee capstone projects where the students get to go and apply what they're learning in the clinical practice. And I was very pleased to see that more and more of those capstone projects are becoming geared towards ACLM principles. I saw that in North Carolina, Louisiana, and other rural areas of Arizona, they adopted some more projects that address the social determinants of health and the pillars of ACLM. So it's building momentum. Next slide.
Yep, so these are just examples of the curriculum. So basically, we built this program from scratch. The first year, as Annette said, the PA students, they use this as their capstone project. So basically, the first group back in 2021, they created the curriculum. And then as the years have gone on, we have just kind of improved upon them. As you see there, the bottom picture of our students, that's them with their ribbon at last year's NACHC conference in Atlanta, where they were recognized. I definitely could not do this group without the students and the help of AT Still gathering the data and helping with a lot of the legwork. Next slide. These are just more pictures of the topics that we go over at the wellness groups. Basically, we present a topic and then the group takes itself. We have some very lively discussions. The patients absolutely love being at the group. They're always asking, when's the next group? Can we do it more often? And that's the plan, to hopefully expand these groups and do them more frequently by gathering the data and proving the efficacy of these groups. Next slide. These are just more pictures. One of the main things that we do at the end of each group is we go over a SMART goal. And those are specific, measurable, attainable, realistic, and time framed. Basically, we try to get every patient or participant to come up with a goal that they want to work on over the next month. And then at the next group, we go over the SMART goals just to try to keep each other accountable. Next group. So this is basically what we do at each group. Like I said, it is once a month. We meet for 2 hours. It's usually the first Friday of each month. And like I'm saying, we've created our own curriculum, but we're definitely wanting to make it more scalable, where Annette and the faculty at AT Still can implement this into the didactic training for the students. And then as they send their students across the nation to other federally qualified health centers, we're trying to make this scalable. So like I said, these are some of the topics we go over. And basically what we're trying to do is create an open discussion of support where patients can ask questions and be vulnerable. You know, a lot of the participants are diabetics, and a lot of them don't even know what an A1C is. So we deal with low health literacy here in this area, which is very, very important to get the participants and the patients to understand what exactly is going on with their health. Next slide.
So one of the projects of our most recent cohort of PA students was to try to explore why we have a high level of attrition, which has been a common theme throughout all of the years that we've had PA students helping Will. And originally the students thought it may be a transportation issue, but through exploration, the students discovered that a lot of times it's because the patients were double booking themselves for other doctor's appointments at the time of shared medical appointments. There were very few that actually had car trouble, and the biggest concern was reaching them and keeping updated contact information. Their cell phones were turned off, or their numbers had changed, or their addresses had changed. And so that's something that we're going to learn from and incorporate some different strategies next year to address. And then Will can share some of the other challenges and barriers he's experienced with this group.
Yeah, so like Annette was saying, what we initially thought was transportation. We've come to find that's not true. I think one of the biggest barriers is just the disillusioned state that we're currently in. You know, patients have shared this with me at the group that, you know, they're almost scared to go into the doctor's office or the medical visit to discuss their health because they don't understand that what they're eating contributes to their diabetes or their hypertension. So that's why I really love the group approach. We can kind of get it all out in the air, and we can discuss what an A1C is, how food impacts your health, rather than be crammed into a 5 or 10 minute visit and be forced for time. And then you have, as you all know, you have patients waiting, and then that just gets to be very difficult to deliver lifestyle medicine in a good way. So like I was saying, over the years, we've been tweaking this group. Ultimately, last year, I got certified with ACLM, and a few months later, they invited me to the MPS, Mental, Physical, and Spiritual Conference in San Diego. And when I was there, we were talking about lifestyle medicine, obviously, and shared medical appointments. And I was lucky to meet a couple representatives from the Ardmore Institute. And Ardmore Institute, they have created a turnkey shared medical appointment, which is called Full Plate Living. So that's one of the things we're going to do this year is we're going to transition our curriculum over to Full Plate Living. That way we can hone it in here in Georgia. And then as Annette is teaching the students in Arizona, they can take that curriculum out to their clinical sites. Annette, do you want to talk a little bit about the other clinical sites that are doing these shared medical appointments?
Yes, they're in the process of considering that, but we do have some FQHCs in North Carolina, Louisiana, and rural Georgia that have been incorporating access to food, addressing social determinants of health, health literacy, and health education. So they're doing components of this, and we hope to integrate the shared medical appointment into more of these FQHCs.
Yeah,
Next slide.
Absolutely. So if any of you work at a FQHC and you want to integrate this shared medical appointment, definitely go check out Full Plate Living. Like I said, it's a turnkey shared medical appointment that is scalable.
Yes, and the other program that was using Full Plate Living had some great outcomes. And the beauty of that is it's simplified. So we did a lot of different handouts and brochures, but Full Plate Living has some really easy to understand brochures, and they even simplify the diet approach even better to address nutrition for people with low health literacy. It's very simple. But through all the challenges and barriers, I also want to emphasize that we've had some positive outcomes as a result of this approach. So overall, the patients in every year that we've done this, they have all increased their fresh produce intake significantly. 100% of every participant that was involved in the shared medical appointment would recommend to other group members in their community to join. Overall, participants experienced an average weight loss of 29.63 pounds. Their confidence in diabetic food plans increased, and their confidence in preparing fiber-rich meals using whole plants increased. And A1Cs stayed the same and it stabilized for the most part or reduced. Now, I want to show you this chart and explain that this is over a short 6-month period of time. So considering that over 6 months where most patients are trending upward, this we count as success because the patients started to trend downward, and we don't usually see that much movement in A1Cs. It's actually considered success if they can be reduced by 1%, even with aggressive treatment. So the fact that they're staying stable is a positive. Next slide. In addition, some of the behavior changes that are really significant to help with health improved. So the participants reported an increase in 2 days a week of exercise, and their daily exercise minutes doubled. They reported confidence in implementing an exercise program. And two other pillars that we addressed this year from ACLM were assessing stress levels and sleep. And we were happy to see that when we use validated screening tools called the Perceived Stress Scale and sleep validated tools, we saw a significant improvement in perceived stress from the beginning of the program to the end of the program. And we saw a shift in sleep hours. Most of the patients were getting either 0 to 4 hours or 4 to 6 hours. And it improved to 7 to 9 hours on average. So that was a plus because that can carry over. There's a bidirectional relationship between sleep and wellness. So we were happy to see those results. Next slide. So our long-term overarching goals in doing this is we hope to have this carry over and have other federally FQHCs adopt this program. Also, I think there's real value in putting this into curriculum so that healthcare professionals, students in training learn these concepts early so they have more tools in their toolkit to intervene with their patients. So we're interested in creating academic pathways, an academic pathway so that our PA students, when they graduate, can then take some additional courses and become certified as ACLM providers. We want to promote lifestyle medicine and really teach that rather than focusing always on pharmaceutical intervention. Lifestyle is the most modifiable risk that can lead to the greatest improvement. And then ultimately, we want to advance research and science through this project and having it scalable to other FQHCs. Next slide.
Yep. So these are our big lessons learned and key takeaways. I can't stress enough how much I would recommend using full plate living. I mean, we spent countless hours trying to create a curriculum, tweaking the curriculum, making those handouts, full plate living, turnkey. It's ready to roll. I think ACLM also has a program. But basically, our goals are to intervene early, like we said. We're going to try to expand these pediatric groups into other local public schools around this area so we can help the younger generation. And then we're also going to be offering food demos. We have not done that. We've basically just introduced the boxes. But one question that's always been in the back of our minds are, are these patients actually using these boxes? So we think that hiring a chef and cooking some delicious fiber-rich foods will be a great addition to the group. Annette, you got anything to add on this slide?
Yeah, so we want to keep on helping our students with motivational interviewing communication style so that they aren't advising the patients as much as helping the patients find their own motivation to make these changes. We also recognize that since calendaring and scheduling was such a problem, we want to be mindful of that and help the patients so that they can put this as a priority, these shared medical appointments. We also want to make sure that we have updated contact information so these patients are reachable and give them calls before the appointments so we reduce the attrition rate. And one of the things that we're going to incorporate next year is enlisting cultural representatives from the community to come in and guest speak at some of these shared medical appointments to model for them some different strategies and tools that they can use. And we're going to introduce mindfulness activities at the beginning of the shared medical appointments to help them support stress management. Next slide. So here's some of our references, and we really welcome any questions. And I've seen some questions come up from the audience. So please ask us.
Yeah, absolutely. And
And
Stacia, just saw you
yes,
come off mute. And yeah, if you like, if
yeah, I'm
jump
just
in.
gonna jump in because we've had a super
Oh
engaged
my
crowd.
goodness.
So I'm happy.
Yes,
I know you were supposed to do the Q&A yourself, but I'm happy to support. So
please.
okay, so we can start with some of the questions that came in through the
Sure.
platform. I allocated a few that we want to answer live. So this for either one of you, Will or Annette. So you may touch on this comes up a lot with SMAs. You may touch on upon this later, but I've learned that SMAs are not reimbursable at FQHCs. Is this true, or is the workaround to bill individual EM appointments?
So so any of you who want to start a shared medical appointment, I would say it is not easy. The logistics of starting it are very hard, but that's the beauty of partnering with ACLM and us all putting our heads together. So I probably spent 6 months working with my billing department to figure out the billing for this because it just was not going to work for us to offer it without billing. So yes, we are billing for the group. The code we are using is a group code. It is 90853. Knew somebody was going to ask that, so I had that one prepared. But yes, we are getting reimbursed for it. A 90853 is basically equivalent to a 99213 or a follow-up visit. So basically, instead of seeing patients in the clinic for that day, I see a group visit, and that counts for my productivity of the day.
Awesome, awesome. And then ACLM also has a reimbursement roadmap that may be helpful, and we can share that after in an email with the group. Another question that came in, Will, your statistics on African American populations health, are those all of US data, local, or just for national FQs?
That was from US data local to Georgia. And the reference is cited in the reference page, but I imagine that these are transferable to other areas in the nation.
Gotcha. Okay, moving on to some questions about the produce boxes. How often are produce boxes delivered? Do groups meet at times when boxes are not included? Who pays the farmers for the produce?
So currently, we are doing the produce boxes at the group once a month. We also have a program where we can deliver boxes of produce to families in between the groups. So yeah, that's where we're currently at. But like I said, we're going to try to add in cooking demos. And one of the things we're trying to figure out also is how to track to see if the participants are using the boxes because they're obviously not cheap. Currently, my FQHC covers the boxes. The farmer charges us $15 to $25 per box. So with me billing for the group, that helps cover some of the cost of the produce boxes. But hopefully we will get funded for this soon and we can expand it. That's the mission with this.
And I want to circle
Awesome.
back really quickly because I recall that those statistics were actually from the Center for Disease Control as well as Georgia.
Thank you, Annette, for clarifying that.
Mhm.
One more question about the produce boxes that I thought was interesting. What is your pitch approach to farmers? How do you get them engaged to want to participate?
I just got on the phone and started calling all the ones I knew around here. And there was a local one who I I didn't know, but I'd heard of. He's very involved in the community. He's all about it's obvious if you're in this area, the chronic disease epidemic that is all around us. So he's very involved in that. He's trying to change that. So he was happy to get involved with the group.
Yeah, he's a
Nice.
wonderful guy. And the PA students also networked. And I encourage other PA students or healthcare students in training to go out there in their community and network because there are many generous people out there like this Farmer Fredo.
That's awesome. And then, Annette, you had mentioned that going forward, as you look to improve the programs, that you're looking into getting some, I guess, some culturally relevant folks to come in and talk to the group. So another question came in around who else is a part of I guess, the interdisciplinary team. Do you work with community health workers?
Will, do you want to answer that? Or do you want me to say from an academic standpoint or from the shared medical appointments?
I would say from the shared medical appointment.
Okay.
Can you repeat the question again?
Utilize community health workers.
Are we currently?
Yes.
So when I first launched the group, I basically put together like a team, and we had a bunch of team members, but since we launched it, I have not. We've looked into adding like health coaches who can give like touch points in between the groups, but I don't think those are reimbursable for Georgia Medicaid, which is basically the insurance that we accept. But I'm definitely open to ideas if anyone has any, because that we're trying to increase the touch points in between the groups, because currently once a month, I think the group participants need a little more coaching in between, you know?
Yeah, the coaching piece is a big component of that behavior change for sure.
Mm-hmm.
Mhm.
So you talked about a few barriers with the program, including the attrition concerns, but what are some other barriers specifically to the fruits and vegetables that your patients are having? Is it the cost, the access, maybe they don't like it, or not knowing how to prepare the fruits and vegetables?
Well, what I really think it boils down to is the food swamps. I mean, right next to our clinic, there's a McDonald's, there's a Hardee's, there's all kind of fast food that is readily available. It's highly um, full of calories, releases that dopamine in the brain. So I think that I really think that's a big part of it, is this easily accessible food. And fruits and vegetables don't really taste that well if your taste buds are used to just getting inundated with sugar and carbs. So I truly think that is the reason. But we're trying to, like I said, um, show these patients through cooking demos that if they can get off of this processed food, that they can reverse their diabetes, they can reverse their hypertension, and hopefully prevent a major outcome, heart attack, stroke. I mean, cardiovascular disease is the #1 killer of Americans, and it is directly tied to the 6 pillars of lifestyle medicine.
Mhm. We have time for one more question, and then we're going to share a few more resources that may be helpful for our attendees, and then we'll wrap. So the last question, how do you find funding and buy-in for your organization to support additional staff? We know that, being able to prescribed lifestyle medicine is really contingent on having that interdisciplinary team. So think of dietitians, and I know you mentioned health and wellness coaches. That may be tricky, but are there other members of the staff, and how have you gotten buy-in from
Yeah,
administrations to
so that
support that?
yeah, so that's probably the most important aspect of this. You know, if your admin staff isn't supportive of this, then I don't know. Luckily, my admin staff, Shelly Spires, she was very supportive of this. You know, she's a member of ACU. So I brought this idea to her, and she was basically like, "Yeah, absolutely, I support you. Just go make it happen." So luckily, Annette, my wife, a couple of key team members, we've stuck this thing out for 3 or 4 years, and it has not been easy. Like I said, lots of logistics that go into pulling these groups off. But I'm just grateful that we have found ACLM who can help us make these groups better and scale it across the nation.
Thank you so much. Well, I want to thank, first of all, the audience for such engaging, thought-provoking questions, and both Will and Annette for your time and leading us through this program that is truly making an impact. on health outcomes in rural Georgia. And then, of course, I want to thank our moderator, Suzanne. Thank you again. It's always fun hanging out with you in ACU. We're going to get to a few more slides just to share some resources before we end. So many of you are probably familiar with our Essentials course, but we are offering it complimentary until the end of September, I believe. And it's really a foundational course to kind of get your feet wet in the lifestyle medicine and food as medicine space. So please take advantage of the free code and the free program and just get your feet wet in lifestyle medicine. Next, we always want to plug and invite anyone interested in lifestyle medicine and being united with clinicians who are really eager to transform healthcare through lifestyle medicine to become an ACLM member. We have tons of resources that are available for our members, of course, our conference, tools and toolkits. So learn more about membership and come join us. We'd love to have you. And then, as I mentioned, our annual conference, we have one every year. This year, it will be in Grapevine, Texas. We're having it in person, but we also have an online option as well. And we'd love to see you there. This is, again, an opportunity to be fully immersed in lifestyle medicine. And we hear a lot of feedback from members that our conference is where people feel seen and heard and where they feel like they've found their people. And then, of course, certification, as Will mentioned earlier, we provide FQHC clinicians with a 50% scholarship if you're interested in being certified in lifestyle medicine. I shared the link to that in the chat. And then anyone else who may not be an FQHC clinician, certification is still an opportunity for you to lean into. So follow this QR code to learn more about how you can get certified. And then thanking everyone who joined us, some contact information, and then of course we want you to stay in touch. And there are various ways to do so. You can visit our website and then also follow us on our social media channels. Any parting words from the panelists or moderator before we wrap up?
I just want to say once again, thank you for giving us this platform to share these shared medical appointments. I really think that we can change the outcome of the current generation and the future generation. So I just love the work that ACLM and ACU is doing. So I just truly appreciate everyone.
Thank you, Will. And we will be following up with an email that includes the recording to this session. So if you want to share it, please do. And then also some additional resources that may be helpful.
Yes, and I want to thank everyone as well. I just really want to thank everyone as well and just say I'd love to continue this conversation. If you would like our contact information, we're happy to share that as well.
And thank you so much to Will and Annette again. What a wonderful presentation, and to Stacia and the folks at ACLM for their continuing partnership.
Awesome. Thank you so much, Suzanne. And we look forward to seeing everyone else soon on another webinar, perhaps. Thank you for joining us and enjoy the rest of your day.